Welcome to the Orchestrate All the Things podcast. I'm George Amatiotis and we'll be connecting the dots together. Today's episode features David Scales, Chief Medical Officer at Critica and an Assistant Professor of Medicine at Weill Cornell Medical College. Scales specialized in internal medicine and also has a PhD in sociology with a particular interest in the sociology of science. Did you ever wonder how data is used in the medical industry? The picture that emerges leaves a lot to be desired. In the early 90s, the evidence-based medicine movement tried to make medicine more data-driven. 3 decades later, we have more data, but not enough context or transparency. The conversation with David covers the fundamentals of evidence-based medicine, how data is generated through randomized controlled trials and accessed via Cochrane Reviews. We draw parallels with best practices in data science and data governance, touching upon provenance, context, and metadata. We also explore the dark side of data in the medical industry, pharmaceutical company involvement, bias, the controversy around Cochrane, and the tyranny of the randomized controlled trial. We also explore predictive models and data parasites in COVID-19 times and the role of the World Health Organization. I hope you will enjoy the podcast. If you like my work, you can follow Linked Data Orchestration on Twitter, LinkedIn, and Facebook. So, thank you again, David, for making the time for this conversation. And I think, something I typically do with people I have these kind of conversations with is I start by asking them to say a few things about themselves, their backgrounds, and in your case, that would involve, since the touching point that sort of connected us was your work in Critica. I was wondering if you'd like to also say a few things about that. So, what is Critica, and its mission, and what you do there, basically.
Sure. So I'm currently an assistant professor of medicine at Weill Cornell Medical College. I'm specialized in internal medicine, but also have training. I also have a PhD in sociology, and have a particular interest in essentially kind of sociology of science is part of what I've studied. And so that affects a lot of my current work, because a lot of my current work is on what I would essentially call in the broad bucket of doctor-patient communication.
Mm-hmm.
And that's everything from kind of the placebo effect, which I have one project on, kind of very much, obviously very kind of clinical in the hospital, kind of the doctor and the patient, to other things such as combating misinformation, which is a lot of the work that I do with Critica.
Mm-hmm.
Critica, it's a small NGO. It was started by Jack and Sarah Gorman after they wrote their book "Denying to the Grave," the psychological reasons behind science denial. And we linked up because we were both very interested in a lot of the different factors that lead to science denial, perpetuate science denial, and make it hard for scientific consensus to kind of guide decision making. And so essentially our mission is essentially trying to help ensure that scientific consensus is what guides kind of most decision making, both kind of public decision making, policy decision making. That's essentially our goal. I mean, we see obviously scientific consensus is something that can be contested, but it's the type of contesting that should go on among experts. And consensus should be revised, but that consensus is what should guide our behavior as non-experts and policymakers.
Mm-hmm.
My role in Critica is basically I'm the chief medical officer, which means I just have an kind of extra time to weigh in on a lot of the medical aspects that we focus on. So we have a number of different kind of projects and protocols that we're working on. And so I kind of weigh in on a lot of that, and bring in my kind of sociological expertise as we try to put that mission into action.
Mhm. Okay. Thank you for the introduction. And so I'll try to give little background from my side because for people who may be familiar with my work, what you do, at first blush may not sound, that relevant or that familiar because mostly what I deal with in my column has to do with, data, databases, data science, data-driven decision making, this kind of thing. There is a line that connects these two, but it's not entirely obvious at first blush. So I'll give a little bit of background to make it more clear, maybe. So the way I came to know about Critica and what you do is through a letter an open letter that was sent, signed by yourself and Critica's co-founders, Sarah and Jack Gorman, a letter sent to Nature, in which he called for counteracting pseudoscience with respect instead of ridicule, as it's also mentioned as a reply, let's say, to another letter sent by another scientist, Jamie Caulfield from. I don't remember his exact affiliation to be honest, but he's Canadian. And well, in his letter, he kind of scoffed, let's say, against pseudoscience, and he called for a kind of different approach. And that letter resonated with me for a number of reasons. First, from a purely communication, let's say, point of view, I think what you called for is just plain more efficient, basically. And it also touched me on another level. So basically, one of the pillars, let's say, of science and research, which is exactly what this is about, is keeping one's options open and being open to revising beliefs, and what you basically also touched upon in your introduction. So I think that especially in this climate where uh, science is kind of being conducted out in the open and for everyone to see. There's a danger that lurks here. So having blind faith in data and data-driven processes, and this is something I've also kind of touched upon in previous columns. So in a way, more and more organizations are turning towards this evidence-based way of decision making and operation, and this is also true for healthcare and for organizations operating there. And this is why data scientists are in such high demand. Uh, However, there's a famous saying in the data science world, which is garbage in, garbage out. So your findings can only be a function of the data used to drive them. And so this brings us to another very interesting viewpoint that you put forward: the analysis you did on what you call the Cochrane controversy. And I've already spoken too long for my part, let's say here. So without any further ado, I'll just let you explain in your own words what Cochrane is, what the controversy around it is, and where data comes into play into this picture.
Sure. I mean, this is interesting, and George, I'll be very interested to kind of talk more because the kind of the work that you do on data and your audience, I think is exactly some of the folks that Critica would like to reach, as we think about exactly kind of what constitutes evidence, and how do we understand how data and evidence becomes a fact, which I think is a bit of a crux of the issue.
Mhm.
Um, so you asked about kind of the what is Cochrane and kind of what do they do. So for those that haven't heard of Cochrane, Cochrane is a little bit of the gold standard of evidence in medicine in particular. So a lot of physicians that are working in hospitals or in primary care clinics, it's a difficult thing to make every decision based on evidence. And if I have to make every decision and kind of like go to Medline and do a search to kind of weed through all of the clinical data to kind of help guide my decisions, there's just so many questions and so much evidence, so many papers out there that that's impossible. So Cochrane is an organization. It's a consortium, and it's changed over time. But you can essentially think of it as a loose network um, of scientists and physicians who carry high standards for what constitutes quality evidence, who then do systematic reviews of various different questions in medicine, and publish those reviews as Cochrane Reviews. Um, and these are very high quality. In the sense that they um, often the I don't want to say the last word, because they're often kind of done and redone, but they are very much focused on trying to pull in what is considered to be the highest quality evidence, and that's usually randomized controlled trials. That's essentially the things that make it um, into the Cochrane reviews, and they obviously those randomized controlled trials get assessed for their quality as well. But at the end of the day, when somebody picks up a Cochrane review, they're often using that as a shortcut to, okay, what is the best evidence that can answer my question? And some examples of Cochrane reviews that I've read recently, for example, are, um, is it a good idea to use what something we call BiPAP, which is essentially, if you've ever heard of a CPAP machine, it's something very similar to that. But whether or not that's a good idea to use in people with asthma exacerbations, whether in people with asthma exacerbations we should give them antibiotics when they come into the hospital, whether what is the association between different cultures and antibiotic prescribing among primary care physicians. So a lot of these questions that affect clinical management of patients is the kind of thing that we've wanted answers to for a long time. And Cochrane provides a fantastic service by summarizing a lot of that evidence for physicians.
Mhm. Okay. Um, just to take a step back, because yeah, you mentioned in your answer a couple of things that not maybe not everyone is familiar with. So let's start with randomized controlled trial, if you'd like to briefly explain what that is, and then move on to evidence-based medicine, because this is the core of what Cochrane does.
Sure. So a randomized control trial is let's just break down the terms, right? So a randomized controlled trial is randomized. It's essentially kind of trying to compare a group that receives a treatment to a control group that either does not receive the treatment or receives a placebo.
Mhm.
And it's controlled in the sense that it has that control group, and people are randomized to one of those conditions or the other. And the idea behind that is that that randomization helps to essentially make the study more generalizable, by helping to distribute equally and randomly any potential confounders. And so, if you want to test a medication, then it's a very powerful way to test if it works, because there's a lot of things that go with giving a medication. If you do a trial that does not have a control group with a placebo, for example, it's really easy to say that, oh well, this medication worked, when really, and like that question I just posed of giving antibiotics for an asthma exacerbation, maybe people with asthma would have gotten better anyway. And so you have to ask yourself, does giving the antibiotics actually help reduce the amount of time, reduce the severity? So these are the types of questions that you can answer with a randomized controlled trial.
Mhm.
People also often talk about blinding. You'll hear people talk about kind of, randomized, double-blind, placebo-controlled trials, and these are other things that increase the quality, because there's a even the people in the study can be biased. And so if you blind them, essentially, if you shield the people in the study to the conditions, so that even the doctors giving the medications don't know if the patient is getting uh, the a treatment or a placebo, then that also helps reduce the confounding and makes it so that we can trust the results more.
Mhm. Okay, just to make the connection here with how data scientists are used to think, I would say that this is a very good example of how data scientists also conduct their experiments, their lab trials. So you're basically trying to break down the parameters that influence your outcome, and then you try uh, to take them each in isolation and try to see, okay, so if I change this parameter, what will happen? What's the outcome? And you basically do that for all your parameters, and then you try to come up with an outcome in the end. So would you say that this is, this methodology that you just outlined is what's the core of evidence-based medicine?
Yes, I mean, so evidence-based medicine is you could argue it's a social movement. And it kind of congealed in 1992 with the publication of an article, kind of uh, recommending it. And it's important to know what evidence-based medicine was arguing for and arguing against, because it seems intuitive, right, to use the best evidence we have to make clinical decisions. That seems obvious. But before the evidence-based medicine movement, a lot of decisions were essentially made by deferring to kind of the most eminent professor in the medical college who was probably a very wise physician, but was making decisions based on their experience, based on kind of their clinical judgment, which I'm not saying was bad. It might have been fantastic, but I think the thing was there was no evidence to support that their decisions were good, or who knew if they were even biased against particular subpopulations.
It was kind
And
of
so
internalized.
evidence-based,
It was kind of
excuse me?
internalized knowledge, let's say, without necessarily being transparent.
Exactly.
Okay. Yeah, please go on.
Yeah. So that started the movement, and that movement has gained a lot of momentum. And Cochrane, which started about 25 years ago, has just grown in size, in influence, and in importance, because it provides such a essential service for physicians who don't have much time to try to weed through a lot of the data and put that evidence-based medicine ideal into practice.
Mhm. Okay, so that all sounds in very very good in theory, like a very solid and objective and scientific approach of conducting medicine. And since Cochrane is built around these principles, people may wonder, okay, so what exactly is the controversy around that? And to cut to the chase, I will just quote from your piece what to me was the what is the focus of that. So you wrote that Cochrane relies on what is widely agreed is the highest quality evidence, the randomized control trial, which you just explained, published in peer-reviewed journals. But the thing is that some people argue that data are often biased, both in individual instances of randomized controlled trials and in the fact that most of those trials, most of that trial data comes from industry funded sources. So, would you like to say a few words about who raised the controversy and what it's all about?
Yeah, I mean, this has been an internal debate at Cochrane for a long time. I think the name that's most associated with this debate is, and I apologize, I'm going to butcher the pronunciation of his name, but Peter Gotchi.
Hmm.
He's been a member at the Cochrane collaboration for quite a long time. And so you could very much argue he's one of the pioneers of the evidence-based medicine movement, and he's argued in a number of his books that um, there can be a lot of bias in randomized controlled trials. As you can imagine, if you're a pharmaceutical company and you're trying to show that your drug works, there's a number of slight tricks that you can do, um, that are, within the rules of randomized controlled trials, but that are handicapping your drug to try to make it look better. Um, and that's things sometimes, whether or not and how you do the blinding. Um, uh, Other things such as what control that you pick, because sometimes it's important to choose a control that is kind of the standard of care. But if you're choosing a control that is, for example, no treatment in a situation where no one would actually not be receiving treatment, then that's sometimes something that can affect the outcome in ways that seem to handicap people that are doing drug trials, trying to show evidence that their drug works. So since randomized controlled trials have become kind of the top of the pyramid of evidence, a lot of interests that have a lot of money to gain by, not, I wouldn't say falsifying, because they're doing these studies honestly, but just putting a little bit of a finger on the scale to try to make sure that whatever it is that they're working on comes up with positive results. Um, this is the kind of thing that Peter Gotchi has railed against, and has noticed increasingly that the proportion of randomized controlled trials that are out there in the evidence that are supported by pharmaceutical or other kind of private interests has been growing more and more and more, to the point where he argues that much of the evidence that Cochrane ends up using is essentially coming from what could very easily be biased sources, which raises a lot of questions, right? Because Cochrane ostensibly just takes the evidence that is out there and does these reviews and draws conclusions from it. But if the evidence that is out there is biased, then as George, as you said earlier, garbage in, garbage out. Peter Gotchi is worried that if the best evidence we have is tainted by bias, then we're just, it's possibly garbage, and then Cochrane is possibly only taking that garbage and putting it through their machine, putting this imprimatur of a non-biased systematic review, and therefore kind of cleaning the garbage and making it look like it is perhaps better than it is. And so this has created a large controversy where he has, in very, you could argue, impolite ways, criticized Cochrane for this approach, and argued for a much more stringent way of determining bias, and inclusion of the trials that Cochrane might use.
Mm-hmm. Okay. Well, to me, it sounds, this kind of argumentation does sound plausible. So, if all or most, at least, of your data comes from one place, and that place has, a vested interest in making that data look, one or the other way, then yes, any, I would say that any, not just any data science, but any kind of, reasonable person would kind of question the validity of the conclusions you can draw based on that data. But then, to me, the question would really become, okay, so is there anything that can be done about it? Because to a large extent, I would say that, it also kind of makes sense that most of Cochrane's data would come from pharmaceutical companies because, well, they're the ones that are largely producing, medications and doing trials. So, is there anything that can be done about it? Is there anything in his argumentation or anything that you have in mind that could be done to alleviate that?
I think this is what gets to kind of the crux of the issue, because I think people at Cochrane, I don't think there's a single person at Cochrane that doesn't recognize that the potential for industry bias is a problem that can sway Cochrane reviews, but it's more a question of what to do about it. And I think that's where there's a lot of very passionate people on various different sides of the debate, and there's not really a consensus because And this is something that I think your data scientists that read your work, George, would appreciate, is that um, trying to trying to weed the bias out of your data is extremely difficult. You essentially have to pick which biases you want, or at least if you can't weed out the biases, then at least try to be as transparent as possible about what biases might be there, or make the data as transparent and kind of your metadata as transparent as possible, so other people can look through it to decide what the biases are. And so there's a number of solutions that are kind of along these lines. Like, some people are suggesting that, well, more public money should be put into randomized clinical trials, because they're essentially a public good. And therefore, one way to reduce the bias is to make sure that non-biased studies are set up, so that there's not one particular interest that's being represented, and using public money to do those studies. There's others that just suggest, any randomized controlled trial is often an enormous multi-year undertaking that gets summarized in what's often like an 8-page journal article. So there's no way to highlight all of the important details and the potential biases in such a small journal article. Um, and so people have been calling for, essentially trial registries to put all of the information from these trials in one location, so that those that are really concerned about some of these issues can, dig into the weeds and decide whether or not there's any additional biases from some of the original raw data. So there's a number of solutions out there that some people are suggesting, and some others are even suggesting that we need to revise what we consider as evidence, because the answer might not necessarily be to double down on randomized controlled trials as much as to recognize when randomized controlled trials make a lot of sense to do, like with a therapy or treatment, and when some other type of evidence gathering needs to be done, such as with a complex intervention where it's really impossible to control for all of the potential confounders.
Mhm. Okay, yeah. Again, what you outlined makes sense to me, even though I'm an outsider in your domain. Just coming at it from the data science or critical thinking, if you will, point of view, that all sounds reasonable. The problem I would argue with those approaches, in a way, is that they sound radical, basically, and that's, to me, that's not necessarily a problem. In that, as we said, oftentimes you need to rethink how you do things, but for many people, I acknowledge it may be an issue that this is quite disruptive in a way. So I'm wondering if you have an idea of how this could be done, and to bring another angle into this. And like we said, this is a very timely, I would say, opportunity to be having this discussion, because of the whole context, and how science and medical research has been accelerated and so on. So to bring another angle into this discussion, I would say that a few people have in the past kind of put forward similar questions, not just for Cochrane, but for the World Health Organization, arguing, for example, which is kind of true, at least to the best of my knowledge, as far as I've been able to research, that a lot of the funding that goes into the World Health Organization comes actually, from the same pharmaceutical companies, and it's actually tied to specific outcomes, research into specific diseases and so on and so forth. So the liberty that the World Health Organization has to pursue its own goals in its own ways, perhaps limited. So, and I'm bringing that into this discussion because one kind of natural thought would be like, okay, this sounds like something which is really big, and that needs a kind of really global discussion and an umbrella organization to host that discussion. But if we have the WHO, which most people would think of as the most appropriate organization to do that, and we have also similar kinds of questions raised there, then one doesn't can't help but wonder, okay, so what is there to do, and what's the right what's the right framework to raise these questions and have this discussion.
So, George, I'm not sure if I understood the question exactly.
Right. So I'll try to rephrase it. So I was just saying that these ways of dealing with bias, basically that you mentioned, they do make sense, but they also sound in a way disruptive because they would mean that we would have to rethink a big part of how evidence-based medicine is conducted, basically. So that's one part of of the comment/question, let's say. So in order to do that, the second part would be like, okay, what's the best way to have a discussion about something which is potentially disruptive? What's the right organization to do that? And therefore, that brings us to the whole issue of the World Health Organization, for which the same kind of questions have been raised. The same kinds of questions that have been raised for Cochrane, like, okay, does the business model does the business model affect the way that Cochrane works? And therefore, the same kind of questions have also been raised for the World Health Organization. So my question is, and I realize it's a complex one, and there's a number of questions lurking, let's say, in there, but I'm trying to make it a little bit simpler. So my question is, okay, so which is the right place and the right way to be having this discussion about rethinking the way evidence-based medicine is conducted?
Mm. So, George, one of the things I would say is the idea that some of the recommendations are radical might be true, but I think this is why it's important to kind of go back to the beginning of the evidence-based medicine movement, because thinking about kind of where things stood in 1992, where there wasn't necessarily a good framework for thinking through how to make some of these decisions and what evidence to use. We now have evidence hierarchies. I think the problem is that there's been a lot of unintended consequences from basically setting up those evidence hierarchies and putting so much weight on randomized controlled trials. Because this might not be something that data scientists run into frequently, but this is something that I see a lot, which is the application of randomized controlled trials to situations that don't really lend themselves to a randomized controlled trial. For example, I can give you so there's a concept that some data scientists might be familiar with called hotspotting. This has been used in crime statistics. This is the idea of kind of somewhat using big data to pinpoint exact locations where crime has been the highest. And it's been applied to medicine in situations of like trying to find the places where, in the United States at least, where kind of the healthcare spending is the highest. And there's a famous group that works in Camden, New Jersey, that's done a lot of hotspotting and trying to put extra resources towards the group of people that are considered to be the highest utilizers of healthcare. With the idea of, if we put more resources into helping these people, then we can hopefully keep them healthier and keep them from costing the health system so much money. Mm-hmm. So all of this makes a lot of sense. And so they had created a very kind of labor intensive and expensive program of kind of targeting these hotspotters. And people had the idea of doing a randomized controlled trial of randomizing people in this area to getting this extra intervention that was trying to help coordinate people to extra social services, or they were not put in this program. And basically, using the rubric of a randomized controlled trial to try to answer this question. And this study came out and it showed that there was actually no difference between the group that got the extra intervention and the group that did not. They essentially had equal hospitalizations over the time period that they were studied. And so that's one of those things where it's easy to think that, I guess this intervention didn't work. We shouldn't put our money into it. But context is often key. And the question that we often need to be asking is whether or not a randomized controlled trial really can control for all of the variables. Because one of the important factors in this study is if you're going to take complex, patients with a lot of complex social needs, and you're going to provide them a lot of coordination to other services, you can imagine how well that program works is dependent upon the other services that those people are directed to. And one of the people that was, very intimately involved in the creation of the group, kind of recognized that a big problem with the study was that they were, quote, coordinating to nowhere. And in the United States, where they were working, there really actually wasn't much in terms of extra services that they were coordinating them to. It was a good idea, but using a randomized controlled trial, it was essentially testing no intervention against this intervention that didn't actually have the firepower to help anybody.
Right.
And so what we've seen is a kind of this reliance on randomized controlled trials as the epitome of the highest quality of evidence. But the unintended consequence has been that randomized controlled trials are probably being overused. And so you could argue that we've actually become radical about using randomized controlled trials and applying them in situations where they don't actually make sense. And so, that kind of points to your question of whether or not these things that people are suggesting are too radical. My argument would be our perspective on randomized controlled trials. In some people in economics that advocate for randomized controlled trials in complex social situations have actually been called randomistas, kind of suggesting that this is a political ideology that they're clinging to, despite the fact that there's a lot of confounding variables that can't be controlled for. So, and a number of people are starting to talk about the tyranny of the randomized controlled trial because it's being used in situations that don't make sense, and also in situations where the research question, the research methodology should fit the question, and so it's being used inappropriately in times where the research question begs a different methodology.
Okay.
And in terms of places like the World Health Organization, I mean, it's interesting that you brought that up because there's a lot going on at the World Health Organization that is beyond simply what evidence the World Health Organization uses. Because the best way that I could describe a lot of the biases that the WHO runs into is my PhD dissertation was actually looking pretty closely at the World Health Organization, and one of the key things that I found was in interviewing one of my informants there was he used the term, he said, our clients are our member states. The WHO functions not necessarily to improve the health of individual people around the world, but to serve its clients, which are its member states. And so a lot of what the WHO does and a lot of how it reacts is not necessarily based on the best evidence, but it is a highly rational organization. But that rationality is often based on the clout of different member states and what those different member states want. And so industry has made its way into the WHO through governments such as the United States that promote a lot of collaborations with industry. But this has also created a lot of consternation, which you might have seen kind of there's been a number of mechanisms where this has become kind of a dividing line. One of the best examples was in 2005 and for a few years after, Indonesia refused to share influenza viruses because the influenza viruses that influenza shared with a global network became patented by Australian pharmaceutical companies. So needless to say, Indonesia was reticent to share things that they might then not be able to afford because they were produced by Australian pharmaceutical companies, and so stopped sharing. And it's created a number of dividing lines. that essentially comes down to what is the role of industry in general in a lot of the work that the WHO does. And so it's not just the trials, but it's everything from how your influenza vaccine gets made to how much the WHO recommends sugar be in an average person's diet.
Okay, okay. Yeah, I realize, this is a huge topic and we could probably be talking for hours just about that. But just to move on a little bit, because not because it's not interesting, it's super interesting, but there's a number of other topics that I'd like to touch upon. But quickly before we get to those, you mentioned that, basically the gist of what you said earlier about the randomized controlled trial is that it's not always the best method to use for everything. Are you aware of or other methods, other methodologies that people are using? They may be at early stage, but are you aware of any of those that could be more suitable for different situations?
Yeah, I mean, I think it very much depends on the question. Um, and so that's often the key is rather than kind of you know um, you know pulling out a randomized controlled trial at every opportunity, or what I often hear when I'm working in the hospital is like, oh well, that wasn't a randomized controlled trial, with the assumption that because it was not a randomized controlled trial, it doesn't tell us anything.
Hmm.
I think is a reflection of bias itself, because there are certain times that it's impossible to do randomized controlled trials in any reasonable framework of time. And one example, so Trisha Greenhalgh um, at the at Oxford is someone who is a little bit on the other side of the Cochrane controversy, and has written some articles, discussing a lot of this. But she's someone who I think is on the right track because she talks about other instances where different types of empirical studies are warranted. And one example that she gave recently in an article on Boston Review is all of the public health measures that we're talking about in a pandemic, of asking the question of, do masks work, hand washing, social distancing, wearing eyewear, a number of these things that you could argue would actually make a lot of sense to do in a randomized controlled trial, but we don't actually have the time to do a randomized controlled trial for these different public health interventions while we're trying to control the spread of a pandemic. So one of the things that she talks about is how in this situation, because time is of the time is of the essence, um, we might be limited in what we can do. And so sometimes we need to draw in other types of evidence. She describes at times we need to bring in some narrative evidence. And also in a case like this, I think modeling is extremely important because that is sometimes the closest approximation we could get to a some sort of trial within the time frame that we would need to be able to implement a lot of these public health measures.
Hmm.
I do a lot of qualitative work, and so I also find qualitative data extremely important, not on its own. I often talk about how quantitative data is extremely important and can provide a lot of insights and raise a lot of questions. That quantitative data can be used to help kind of really extract the context. And I think the combination of quantitative and qualitative data is extremely important. And yet, kind of our evidence based structure prizes the quantitative randomized controlled trial data without enough of the qualitative data to put those trials in context. Just like the trial of hotspotters that I mentioned, that was done in a randomized controlled trial. I think that's fantastic. I think we should do a randomized controlled trial. But I also think what's equally important is some of the qualitative data that puts that trial in context to help explain why it might have failed, so that the next time we can actually do a trial and improve upon that, rather than just make the overstated conclusion that, like, oh, these hotspotting programs don't work.
Mhm. Okay, so just to give a little bit of context on qualitative data, in data science or data governance parlor, I would probably call those metadata or context, adding metadata and context to your data sets, basically.
Yeah, and I would say the two need to work hand in hand. And it's unfortunate because right now there's so much emphasis on the quantitative that what we're getting is we're getting an overabundance of quantitative data without sufficient context, that it's making it hard to see the biases and the challenges and the problems that a lot of these randomized controlled trials might have.
Hmm. Okay. Let's move to since you mentioned the pandemic earlier, and it's obviously the backdrop for this discussion. Let's quickly assess a couple of cases that are related to that recently came to light. And let's start with modeling. You refer to modeling as one potential way of doing research in cases where it's ongoing, or you maybe want to have some predictive results in advance of whatever is taking place. And one kind of famous or infamous, depending on which way you look at it, model is the one put forward by the Imperial College by this professor named Neil Ferguson, on the basis of which a number of decisions were made earlier in the course of the pandemic. And as you may know, this specific model was later scrutinized by a number of initiatives and researchers. And what they found was that in terms of quality of the software, or how it was maintained, and whether it was transparent or not, it scored pretty low on pretty much all of these dimensions. So, in a way, I would say that that kind of brings forward the question of how much we should rely on these models and under what conditions. And to tie that to something that you referred to earlier, um, you mentioned how many people have suggested that in the case of randomized controlled trials and Cochrane, since these are essentially results that have to do with public health, perhaps they should be publicly funded and therefore belonging to the public domain. Do you think that the same could be said for models, for example, that these things should be open source and transparent and open to review?
Uh, I absolutely agree. I mean, George, one of the subtexts of a lot of what we're talking about here is the incentives um, that different researchers have for kind of the work that they do. And one of the challenges is that the incentive for most researchers is to keep things private, because if they keep things private and they advance a model or even a randomized trial, um, that advances their career. Where if they make it public, um, people aren't necessarily going to cite their work, is their fear, and so that then might hurt their career. They might be able to kind of put something out there, but then it doesn't get them any more research funding. It doesn't get them more papers. And so if they can protect it, then they're protecting their career. And I think this is rational, right? This is one of the things that is a very very common thing, at least in medicine and a lot of biomedical research, is that just assumption that things need to be private in order to make money off of them or advance a career. We see this with patents, with pharmaceutical industry work, all the way to some of these models. But I think, George, what you're pointing out is that a lot of people that come from software and are familiar with open source and the global public license and a lot of the efforts to make things in the public domain see that has actually made things better for everybody. Um, and I think this is an ongoing debate and definitely not my field of expertise. But the thing that I see is overall the more transparency there is, the more robust the science becomes. Not just with modeling, but I would actually argue with almost all of the statistics that we do. There was a fantastic paper that was published in 2018 that I can send you, George. That it's called "Many Analysts, One Data Set," and they say making transparent how variations in analytic choices affect results. This doesn't sound like a thrilling paper by its title, but what they did is they essentially took one data set, which was an interesting data set, for Europeans listening to this. It was a data set of whether or not soccer or football referees seemed to have any bias towards dark-skinned players when they were calling fouls. And so they took this data set of fouls and race, and asked 61 different teams to analyze the data, and they got 61 different ways of analyzing. There were multiple different types of analyses, and they got a wide range of results. And any one of these probably could have been published in a journal. But I think what was interesting was by kind of crowdsourcing this, they probably got a little bit more towards a better sense of what might have been going on, rather than just publishing one single paper and keeping the data set private. So I think, when it comes to models, George, like exactly the one that you're describing by Neil Ferguson, and arguably much of the statistical research that we are doing in medical and economics and social science journals needs to be in the public domain and needs to be available for everyone else to do analyses. But in order for that to happen, researchers would need to get credit for that secondary analysis. And people that created these data sets would need to get essentially kind of more credit for the data sets than for the papers that come from them. There was a debate about this even in the New England Journal of Medicine, where the editor-in-chief called a group of people, quote unquote, data parasites, on the idea that, if someone did a clinical trial and made the data available publicly immediately, that there would be a lot of data parasites that would steal the data and do a lot of analyses before the team that had put all of the blood, sweat, and tears into creating the data and doing the clinical trial kind of got their just reward of publishing the paper that they wanted to publish. And, I think the argument behind that, rightfully so, the editor-in-chief got pilloried by calling people data parasites, because, this is the kind of thing where the more this stuff is analyzed and tempered in kind of the scientific spheres where we can have these debates, I think the more robust our conclusions would be, both with modeling and the statistical work. But there's a cultural shift that has to happen, and the academia is lagging behind in providing the incentives that would make this a lot more feasible.
Mm-hmm. Yeah. I think many people in the data science and machine learning community would actually cringe by hearing this story, because for them it's pretty standard that you may get a lot of value out of data sets that other people produce, and you may reuse them in very imaginative ways, and this is the norm, basically, I would say. I mean, in parallel, you do have the fact that many organizations cling on to their data sets because they get lots of value out of that. So there is that as well. So these cultures kind of coexist in parallel. But to me, my experience from talking to many people who work on the field is that they totally see the value in what you describe, in just getting additional value out of reanalyzing and interpreting somebody else's data set. So yeah, to call this work, to call someone that does this work a data parasite would be kind of unheard of, I would say.
Yeah. I mean, I see what the editor in chief is describing in the sense of like if you the amount of work that goes into doing a clinical trial is enormous, and that should be if you are part of a team that does that work, there should be a reward. But I don't necessarily agree that reward should be that you simply you he was arguing for data protection, uh, and, and which is one type of reward to allow people to kind of write the papers that they want. But my argument would be, rather than protect the data so that they can write, one take on how to analyze the research, my thought would be let's figure out some way to reward the people who put the effort into making that data robust to begin with. And there's not enough effort put into doing that.
Mhm. Yeah, I don't know, a very simplistic maybe way of thinking about it would be, data sets should be citable just like publications. So if I use a data set created by some research team, then I should cite them in my publication. And that for people who do research professionally, that certainly counts for something.
Yeah, I would agree with that.
Mhm. And so to kind of wrap up, let's visit another topic, which actually has to do a lot with this what I would call data provenance, because again, to kind of mix the two words in the data science parlor, what we're talking about. So having knowing the origin of your data set, basically, and giving proper attribution where attribution is due. It's called data provenance. So, a recent incident that kind of touches upon this aspect is a study conducted on the effectiveness of chloroquine, which involves an entity called Surgisphere. So, in a nutshell, what happened there is that what was initially referred to as the most influential COVID related research up to date was called into question as the result of lack of transparency regarding the origin and trustworthiness of the data it was based on. So the researchers who conducted the research based their findings on data acquired from Surgisphere, which is a startup claiming to operate as a data broker and providing access to data collected by a number of hospitals around the world. However, whether that data is veracious or whether the data has been acquired in a transparent fashion is not clear. And as a result of that, the results of the research were put into question, and the decisions made as a consequence by the World Health Organizations have been reverted. So the question there is that, do you think that people who did this research, and not just them in specific, but people who do any kind of research and acquire data sets as part of that, have a sort of responsibility to verify the sources of their data?
The short answer is yes. I think there's obvious challenges to that. It's often, I think for your data scientists, they would know that data can be very deep. And so knowing the data and all the metadata to the degree that is sometimes required to know it as well as the person who constructed the database is often, you're never going to know it as well as they did. But I think there needs to be a due diligence, and I don't think it's people can abdicate that responsibility by just saying that there's an aggregator of data. I think it's important to recognize that the quality of data is extremely important. Knowing the data provenance is extremely important, and your responsibility as a researcher. And people have to researchers have to sign a document saying that they have examined kind of the quality of the work that they are submitting to a journal. So it's hard for me to understand how people can sign that document when they're submitting to a journal without doing the due diligence necessary for a lot of the controversies that we're seeing out there about data provenance.
Mm-hmm. Okay. So, yeah, we've covered lots of ground, and we could easily go on for a long time too. But since we have to wrap up quickly, then I would just do that by asking you whether you think there is, well, obviously, people who conduct medical research are very well trained or have to be very well trained in their specific domain. Do you think, however, that uh, getting them exposed to some additional training in data science techniques, like how to manage data sets, or keeping track of provenance, and perhaps even going as far as trying different data analysis techniques. Do you think that would be beneficial for them?
Yeah, George, what I would actually say is we should have enough training to know what we don't know. But I'm a big fan of a division of labor, and I recognize that it doesn't make sense for me to get so much training to be able to kind of manage my own relational database and put in the metadata myself, as much as to know what would make a high quality relational database and be able to hire someone who can actually do that.
Mm.
So I do think more training is necessary, because I don't even think we're at the point on the medical side, at least, that we know enough about data science to be able to even always kind of hire the right people and collaborate with the right people who are doing this well. Um, but but I think there needs to be a lot of education on that front, and because what I see and is that, excuse me, that a lot of physicians are getting education, and a lot of scientists are getting education, but there's an assumption that oh, if we just take a couple of courses in statistics, then we can do our own statistics for these papers. And a lot of times, what I see is we don't know what we don't know, and we're often applying statistical tests that we shouldn't be applying in certain situations, not digging deeply enough into the data to be able to describe kind of what biases are there. And it's sometimes beyond our expertise, but we need to be collaborating with people who can help us do that, because uh, otherwise garbage in, garbage out, and a lot of what ends up in medical journals can sometimes be um, of poor quality.
Okay. Okay. Thanks. Yeah, you've summed it up pretty nicely, I think. Thank you. It's been a super interesting discussion, one of the most interesting and the most enjoyable I've had. So thanks a lot for your time. I hope you enjoyed the podcast. If you like my work, you can follow Link Data Orchestration on Twitter, LinkedIn, and Facebook.